Welcome everyone to our webinar. I'm not going to say good evening as we have people from the UK and the US and indeed Canada, Japan, Afghanistan, Bangladesh and Brazil. So it's more international than our usual Cambridge Health Network events. I'm Pam Garside. I'm chair of Cambridge Health Network and we're delighted to be co-hosting this event with McDermott, Will and Emery, who are a long-time supporter of our network. Our network was formed to bring the public and private sector together at a senior level in the UK, based out of Cambridge. This topic of health data and digital health has been brought into particularly sharp focus, as we all know, during the COVID pandemic, with lessons for health systems and for enterprises and for governments post-COVID. So we're looking to the post-COVID world. And public and private sectors have been wrestling with policy for data use for the last few years as these digital services develop. That's all I'll say as a contextual introduction. We have a terrific lineup of speakers you'll see here. Beverley Bryant, who's Chief Digital and Information Officer for King's and Guy's and Thomas's Foundation Trusts. Michael Macdonnell, who's Director of Global Deployment for Google Health. He's based here in London. Stephen Bernstein, who's partner in McDermott, Will and Emery, based in Boston and focused on digital health. And Sharon, who's also a partner at McDermott here in London, leading the health practice. And here's our agenda. If we could flip to the agenda, we've got three buckets, three areas we're going to explore, with a couple of polls involved as well and discussion time. Thanks, Mel. A couple of procedural issues. This is being recorded. And if you could use the Q&A function to submit questions or comments, that would be great. And I'm going to hand over to Sharon now, who's going to take us through the first couple of issues. Thanks, Sharon.
Yeah, thanks, Pam, and thanks everyone for joining us. I can see participants coming in quickly here, so it's a topical subject. I think we had over 300 registrants, so something that all of us are interested in. The first topic that we just looking at is the question of digital infrastructure, data, and I'm going to ask each of our kind of panelists, kind of Beverley, Michael and Stephen, to kind of address kind of particular points here. And we knew pre-COVID that there was a critical need for the use of health data in the best way possible, but particularly looking at the digital infrastructure. What did we have in place? What worked well? Beverley's just starting first on that, then a question for you. Knowing what you know now, and of all your experience the last few months even, what was your experience of what worked well, what didn't? What has your experience been?
Yeah, thanks, Sharon. So obviously I've been trying to drive for uptake of digital maturity across the NHS for a number of years. And what struck me was that there was a moment in about the third week in March, just before lockdown, and in the acute sector, certainly in my experience, where site leads, operational teams and critical care clinicians kind of went one of two ways. Those people who were already operating with digital technology, that already had the infrastructure in place, started to say, look, we need more laptops, we need more training, we need more licenses, we need it now. We've got to ramp up of staff, bring me the tech, bring me the kit. And that was the view. Those parts of the system that were not using digital, they weren't culturally used to a system where they were, it was properly embedded, basically said, right, it's a crisis, back to paper. We've got to use it. We've got to capture our stuff from a paper perspective. And they started to feed the statistics into spreadsheets. So the point being that it was too late by then to try to persuade anybody of the benefits of digital. If you weren't already on the journey, you weren't going to get on that journey in the middle of a crisis. Meanwhile, the cancellation of outpatient appointments saw a clamour to technology. So consultants who had previously said, no, sorry, I cannot see any of my patients virtually, I've got to see them all face to face, suddenly realised that there was going to be a mass cancellation of appointments. They were working from home, and the uptake of technologies, attend anywhere, VPN tokens, you know, the IG demands to be able to have access to patient records, mailbox sizes, you know, huge uptake in demand, fantastically. And of course, some of the national agencies like NHS Digital were very responsive. They were right on the pulse. So again, another positive. And I guess the only other point to make was that without any authority or anybody with any title or from a board telling them to do it, we suddenly saw analytics and informatics professionals stepping up, clinicians and IT professionals, to start creating dashboards, apps to capture symptoms. And there was like, suddenly, without any permission, people just got on with it. So, you know, the key now is trying to make sure that we capture the best bits of that.
Yeah, so I mean, that's amazing, is that get on with it culture. Michael, I mean, what your reflections on Beverley said? I mean, what do we do now? Because I think, Beverley, you were going to come on and say, how do we capture it moving forward? What do we do to kind of move forward, to move quickly to digital health tools and technology? How do we harness the kind of take up in remote consultations? And how do we use and restructure what we've got? I mean, mailbox is a good point, Beverley. Michael, what do you think?
Hi, Sharon. Thank you. And I'm jealous of not having a background like yours, so I could put my head to it. But I'm from Google Health, a relatively new bit of Google, which is focused on helping people take better control of their care, for instance, through our properties on search and YouTube, improving the information that's on there, as well as helping people navigate and take action better. We're also helping clinicians with better tools to look after their patients better, more predictive tools, using data insights to get ahead of the curve. And then we're also involved in improving diagnostics and screening through the application of AI and other data-rich technologies. We've been very active in the COVID space as well, ranging from everything from community mobility reports, which helps governments work out whether the social distancing interventions they've implemented are taking place, through to predictive modeling on behalf of some of our hospital partners and government partners around the world. And indeed in the UK, we've got a mobile application called Streams, which has helped clinicians on the go have access to test results and help plan their care better when we know COVID has altered the way that hospitals run. I mean, in terms of how much it's changed, I'm going to offer a little bit of a provocative sentiment on this, which is some version of we tend to overestimate the short term and underestimate the long term. And I think 2 or 3 months in, we should just have a little bit of a dose of realism. I'm sort of surprised at how much in many countries, for instance, the debate has snapped to apps will solve our problem and forgotten about epidemiological footwork and the shoe leather that really does need to take place in order to get on top of COVID. So I think that sounds a lot to me like the previous debates about AI was going to replace doctors, when we know that actually that AI will just be a partner with doctors and help doctors do their jobs better. So I think let's be a bit realistic here. I think now as ever, the real key is to make sure that technology is married with the way clinicians do their work and the workflow, and the change management problem remains incredibly important. So I think the winning technologies will be the ones that are designed with and by clinicians to help them solve real world problems and actually fit into how they deliver care. And the last thing I'd say is, I think it's probably woken us up to the fact that data assets are incredibly important to us. Again, this is, I don't think, a new insight, but every government around the world should pay attention to the fact that data assets properly curated, public assets properly curated, are going to be part of the future. We need to make sure they have standards and they're structured and curated. These are going to be incredibly important public assets. So those are some thoughts.
Everyone's kind of highlighting the limits of what they can do.
Yeah, I mean that's a provocative question, and I think it kind of adds on to a question I'm going to ask to Steve. I mean, these issues that Beverley's described, Michael's spoken about the opportunities here. What's your experience been in the US? Are there similar? You've been working with health systems, digital providers. Are we seeing the same types of issues, or?
Yeah, I think there are similar type issues. I think one of the differences will come to reimbursement, which is obviously a completely different system. But I think first and foremost, this notion of a clear recognition that the ability to have a dashboard at different levels, this system was woefully inadequate. And I think we saw a lot of organizations, including state and federal governments, running to try to figure out how do you even track who's tested positive, where are they, how much personal protective equipment is there. And all of that data was scattered all over the place and very difficult to collect. And so I think one of the things that is certainly a lesson learned, and I think there was a vibe that was occurring, is that the lack of structured data and interoperability running between and among providers, first and foremost, is still a problem. Second, the communication gap between providers and local governments to figure out where viruses and hotspots were popping up, also woefully inadequate. And then how do the regions roll up to the states that in further and further roll up to the federal government? And there was no dashboard. If you treat COVID as a war, in most war settings, you'd have a war room, you'd know the data, you'd know where the soldiers and the weapons were. Here, there was no idea. And so I think we're going to see, and there were efforts to do this in the US, but I think we're going to see a big movement to structure data in a way that can roll up so that the right organizations get the right data at the right time. Second, totally agree with Beverley on the telehealth aspect and this quick migration to telehealth. I think people have suggested that it accelerated the use of telehealth by maybe 10 years to break through this sort of inertia and logjam. I think the key difference probably in the US is the reimbursement component. So what happened in the US, and this is very peculiar and I'm not proud of it, is that certainly getting physicians to use telehealth to do the treatment and recognize that it's pretty darn good, but it may not be perfect, but that's fine. But then in each of the states in the US, each governor had a declaration of an emergency and relaxed a lot of standards in terms of telehealth and you not having to have an in-person visit to deliver the care. But there were 50 state different rules about what physicians' licensure status could be. Could they practice across state lines? And this is a very archaic situation in the US. And so those got relaxed, but they got relaxed in different ways. So if you have national provider organizations, they had to literally look 50 states to figure out whether their physicians practicing who might reside in New York could deliver care to someone who's in Florida. And they had to look at Florida laws. And so we actually ended up building multi-state charts to do that. And now as the emergency begins to relax, the reverse is happening. Where do you have to go back to the old rules where you can't practice cross state lines? And that was an automatic snapback, or it's beginning. And so I think what's going to also happen is there's going to have to be greater discussion across states to say, hey, we've overregulated this for a lot of political and business reasons. It's silly, and it almost killed half our major chunk of our population. That's ridiculous, and we need to change that. And then the last thing I will say is on the reimbursement piece, if you're not licensed in a state, there were issues about whether you could bill or not. And that becomes kind of a serious other problem. And then the related issue that Michael references on workflow, when you're in a telehealth situation, just the ability to organize a medical record and keep it. And telehealth wasn't all by video. It might have even been by phone. How do you get the information back into the integrated record? Those are things that are a little bit different, driven by reimbursement procedures. But so some similar issues and some different.
Yeah. Beverley, do you agree with that? I mean, some of that is very US specific, obviously, but I mean, there's some common themes across the infrastructure not talking to each other in a way that perhaps we could also learn from here, or do you think we are further ahead on that?
Well, it's interesting to hear that, because we're all very proud at the moment of our NHS, and it's a big deal, and the response has been amazing. But actually, this is one of the reasons why the National Health Service really matters, because without having to worry about those financial regulations, about those interoperability, we've just suddenly, people have gone national license for Attend Anywhere. Mailbox sizes on NHS Mail doubled overnight. Do it. We've had a lot of support from the Information Commissioner's Office. The law is still there, but we're able to tell people if you write an FOI in, it's going to take us longer to respond. So it's just felt extremely positive and permissive. And I'd like to think that it's because we are a National Health Service. And so yeah, it's let's just try and capture some of those positives. And I don't want to deride the American system, but they've got some learning from this that we frankly didn't need to learn, because we already had that national element in place.
Yep, I agree with you. I think some centralization is important. And I think our deployment of technology and associated funds was very dispersed, and it continues to be a problem. Just as an aside, CMS, which runs Medicare, which is kind of our version of a federal payment system for people over 65, the government has done a bunch of different dropping of money into various bank accounts, but then asking for regulatory attestations that you don't have any open claims or open investigations. And then they've changed their mind a bunch of different times, and they've said, oh, give the money back and then reapply. And it's making things nuts. And it seems like the emphasis is on the wrong syllable, so to speak.
So just to come for us, that's going to be after the fact. So the way our system works is make your own judgments, executives, make your own decisions. And by the way, there's going to be a reckoning, and we're going to, after the fact, come back, and you need to account for every decision you've made. And so we've been given a sense of go forth and sort it. And then all of a sudden now it's totally different. All those regulatory questions are now starting to come after the fact.
Right. And that we're on par there in the same way. There will be investigations and looking at who got money, why did they get it, how did they use it.
I would just say too that we can overestimate the National Health Service in England, as well as we definitely have a more integrated system than the US here. But I'm still surprised at how hard it is to data share, in particular between different settings: primary care, secondary care, social care here. I think actually some of the themes, as Sharon says, are actually much closer between the two geographies than is commonly recognized, whether that's interoperability, data sharing, the privacy debates, the role of government in setting standards. These are all very similar debates across the pond.
Okay, we have, thanks everyone. I have a couple of questions coming in. One's long, I'll read it. Have we considered what factors stopped people from embracing technology pre-COVID? While for some it might be a habit preference issue, have we satisfied risk and governance issues adequately? Second bit, would we revert to the old ways of working as we review our risk appetite once we're over COVID? Who's planning on picking up the pieces where pace is prioritized over patient safety? That's multi there, that one. Beverley, do you want to have a go at that?
Yeah, I mean, there's a load of factors as to why they weren't really embracing this pre-COVID. Financial challenges, availability of capital, leadership, clinical leadership and buy-in, skills and capability, historical issues of trying to do it and it not working. We have all of those challenges across the NHS in the UK. For me, the biggest driver, the biggest, if you like, enabler and blocker is the availability of clinical leadership. Because when we find clinicians who really understand how their day-to-day job can be enhanced by the use of digital and data, it happens. I'm the IT director. I can deliver it for them, but I can't make them want to need it. And so where we've seen in the UK strong clinical drive for the use of digital, and this is to echo Michael's point, we have wall-to-wall digital, and therefore through the COVID crisis we've had wall-to-wall data, and all of the innovation has happened. So I think that would be my response to that question.
Okay. Stephen, you're a lawyer. That last thing, you're a lawyer, you can do risk. That last one, who's planning on picking up the pieces where PACE is prioritised over patient safety? That sort of reeks a bit of a post-COVID inquiry, but have you any comments on that?
Yeah, I'm a lawyer. I guess what I would say on that is organizations and consumers they're gonna figure out the risk calculus. So I think the other analog to Beverley's comment is part of the delay was consumers. Let's focus back on the patient. There are different gradations of patients. A 20-year-old is going to migrate to telehealth much more easily than an 85-year-old. We don't have to even elaborate on that. And so the question then is, how do you migrate an 85-year-old or a 50-year-old to play with digital activity or connectivity, make it go faster, and that is the way they're going to get care. And I think what's going to happen is the standard of care, we're living it right now. It is evolving. So what is considered standard practice in a telehealth visit, that will be what is judged in terms of lawsuits and other kinds of risks, so that physicians will be well attuned to understanding and being candid with the patient. I can evaluate you 80%, but I don't yet have a substitute for a physical examination or a particular test. At some point, those will be virtual. They already are. And I think physicians are going to have to be very candid with patients, and patients are going to have to understand that technology works up to a point, and then they're going to have to come see a physician. Or I think what's also happening is physicians will come see them. I think the return to home health and in-person visits in your home, that is the next level of where we're going. I mean, look, we're doing this call from our homes right now, and yeah, I think life is going to change, certainly in the medical world on that point. House calls will come back.
Thanks. Michael, lucky you, I'm not going to ask you that one, but there's a question coming about the tracing app. Clearly the NHS tracing app not yet ready. Are you aware of a tracing app that functions successfully, and what does that tell us about the human tracing that needs to go alongside? You're from Google.
Yeah, I am going to actually answer the first one just briefly too, and just say I think one of the real dangers of this period is leaving aside evidence and safety concerns in an effort to be a little bit more risk-taking, which you can understand the reasoning behind, but I think is one of those things that'll play out very badly in the long run. And I think it's, we've seen with the Lancet publication of hydrochloroquine, and people are rushing to preprints. This is a difficult issue, and I really think from our perspective, and indeed from healthcare's perspective, it's important to hold on to the evidence base. On contact tracing, I don't want to disappear too far down the rabbit hole. I would say, and this is maybe funny coming from somebody at Google, that this is a side issue in a way. I mean, I think that what we call exposure notification applications can be a useful tool, but are only a tool when as part of a wider system, which is shoe leather, epidemiology, actual humans talking to actual humans. And in a thought through way, which involves helping people when they've got to self-isolate and, looking after their needs so that they aren't left without, food or income. These are the really big issues if we want to get back to normal. They're not actually about the architecture of an app. So look, we NHSX, as with any other governments, entitled to pursue their own way of building their own apps. We believe we've got a good infrastructure on which to offer governments that are interested their own. But we definitely believe that it is only one part of the solution.
Thank you. I'm going to hand back over to Sharon. Thanks.
Okay, so our next question then, I mean, this is the topics that we've spoken about. Clearly there's a need for partnerships and collaborations. And I think here we're talking in the widest sense, but I think just for the benefit of this conversation, really good to focus on the collaboration between technology providers, healthcare providers. Both of them require specialist input. Looking to the future and how technology providers and healthcare providers can work better together, we're going to ask a number of questions, but I'm going to throw a poll out to our audience, asking our audience questions about what they think have been the key issues. Are we able to pop up the poll quickly, and I'll read out the question, and if everyone can pop their answer into that. Should be coming up. So the question is, when partnering on a digital health or health technology collaboration, what have been the key issues, and select one option: culture, data sharing and regulatory, funding and cost, time and approvals, and implementation. I'm going to give everyone 10, 15 seconds to pop their answer in. So I think we're done now. Could we show the poll results? Oh, that's concerning, data sharing and regulatory. Culture coming in at 30%, but less concern on funding and cost. All right, I'm going to close that poll now and then kind of pass that over then to Michael and Beverley, just to kind of kick off on as both of your kind of perceptions. You can reflect on the poll, but also your personal views on this. When it comes to technology and data, what really are we looking for if we're going to harness what we've spoken about, take the learnings, move forward in a way that's really meaningful? And what are the key elements you look at? I mean, when you're looking at a project, what is it we should be kind of measuring success against? Is it clinical outcomes, cost efficiencies, kind of combination of those? And then a question on this, because clearly data and regulatory came up as one of the biggest points on that poll. How do the partners share responsibility for that? The transparency to the patients, the responsibility for keeping information safe, kind of reassuring patients that their information isn't going to be shared. Who takes the risk or who is responsible? Beverley, do you want to kick off, and then I'll pass over to Michael to kind of give his views on that?
Yeah, sure. I mean, it's a multifaceted question, because it's in the context of collaboration and partnerships, isn't it? So for any project or program to get off the ground, you really need to sell it on the basis of the clinical outcomes or user experience, because clinician experience, which then leads to outcomes, is often the primary driver. And obviously, but from a business case perspective, there needs to be a financial return, that you need to be able to tell a story and value and return on investment to satisfy sort of investment criteria. I think before any of those things happen, though, to answer the question from the perspective of how do we get collaborations off the ground, what are the key elements to make sure that it's a partnership? I've spent most of my career between the NHS and the private sector. And I do believe strongly in harnessing the relative skills from both sides. But it is difficult. It is difficult in the NHS because, I mean, I don't want to dwell too much on the past, but the National Programme for IT and the PFI programme effectively put collaborations and partnerships back 20 years. And to be provocative, one might argue that we've never really recovered. And there's a trust issue, which I try and resolve everywhere I go, but it is still in the underbelly of many of our organisations. So for me, the key elements to allow any collaboration to get off the ground, notwithstanding the points about clinical outcomes and the money, is the relationships. So where we have shared purpose, shared values between a private sector collaborator or partner and a public sector NHS organisation, it's going to work. Those relationships are the number one factor. Value, and that goes without saying, that a private sector partner needs to be able to offer a skill or a product or a service that's not readily available. So it's that thing that we can't access easily that the private sector provider can provide. And going forward, potentially, as we hit a recession, and we may be also looking at capital, because, if anything, it's brought home for me how crucial digital and data are going forward. And hopefully we'll have a chance to talk a bit about some of the data sharing issues later on. But I do hope to see a renewed and reinvigorated push for data and digital. And there's going to be an appetite for it. And what worries me is that the capital constraints that may follow will mean all this excitement around digital and data will be lost if we can't quickly capitalise, for want of a better word, on the opportunity now. And so I'd be also looking for partners who can help to fund us in the short term.
Michael, do you want to kind of comment on the press points? Big questions here.
Yeah, I think I agree. I agree obviously with Beverley that the basics are really important here. Honesty, trust, shared interests. I think in our experience, being very clear that we are trying to achieve the same goals, whether that's a set of clinical outcomes or whether that's cost. You do need to spend a lot of time up front being clear that you're after the same prize. We also, we've learned, especially in different healthcare, you need to pay attention to maturity as well, digital maturity, whether that's the digital systems that are in place, making sure that, all too many NHS hospitals are still using paper, for instance. It just holds them back. Cloud infrastructure is increasingly more a part of what you need in place to do some of the analytics and AI applications that we're involved in. So you do need to kind of be fairly clear about the levels of maturity in a partner. And then the most important thing, I think, that we, at least when we're talking about pairing up with a healthcare partner, is clinical leadership from our perspective. We want to build applications for clinicians, by clinicians, which means a kind of really deep sort of relationship of UX research and feedback and co-authorship and and trust at that level. And you need to be able to follow them around on the floor, be involved in their workflows, really understand how you're going to change their behaviors, so that you don't end up in a position with, for instance, some of the EMRs that are complained about that just don't, are very difficult for clinicians, that make their lives harder, that contribute to burnouts, that, 1,000 clicks in and out of systems. These are the sorts of things you have to design around by being very entrenched or really embedded with people. So that kind of clinical leadership and involvement is just absolutely crucial to our collaborations. And I would last thing I'd just say, Sharon, the point we've learned, we haven't done this as well as we should have in the past, but we've learned that transparency is incredibly important, and I'm sure we'll come on to this, but the need to be clear to patients and the public. And look, we're clear that we're merely processors of data, but we have got to be in with partners that are willing to and able to talk to their public and users about why what we're doing is good for them and the right thing to do, and able to be open about it. Otherwise, we end up in hot water long term.
Yeah, I think that these are tricky issues. Steve, have you found similar issues in the US? Does it?
Yes, I think our overarching themes that Beverley and Michael articulated are consistent in the US. I think there's another level of detail that I just want to reference, and that is coming into collaborations, there's often confusion, or just, I wouldn't say misalignment, just confusion about what data are we talking about and for what purpose. So collaborations, they run the gamut. If you've seen one collaboration, you've seen one collaboration. I think the notion is What is the collaboration about? It's obviously about improvement of health, but at what level? Are you looking to improve a system to deliver care to this identifiable population of patients by name and these kinds of care pathways? Or it's an and/or really, or is this really about gathering data to build systems to evaluate population health, or is it both? Most of the time it's both. And I think oftentimes we've seen collaborations don't get off on the right foot because that landscape at the front end is not discussed up front. There's lots of assumptions and misassumptions made about what data are we talking about. So that, how data is ingested, from whom, who's accessing it, how is it used, how is it de-identified or anonymized, and can it be used for secondary purposes? That whole continuum chain needs, in my view, needs to get laid out up front, because then the other issues can load on top of it about, okay, we're dealing with identifiable data. Who's going to access it? Can we trust them? What are the privacy considerations around that? And then when you go the other direction on secondary data, there's always the issue, and it is a bit of an elephant in the room. Well, who kind of owns the newly created intellectual property that's built off of identifiable data, where the patient really should be the one controlling it and who accesses it? But as soon as it's morphed and transformed into something else, which obviously requires a lot of systems and activity, of which technology players are playing a big role, that issue needs to be addressed. And how does that get shared? And where does the consumer fit into that? So those are a little bit, in addition, I agree with what Michael and Beverley said, but that's another piece that we've seen cause collaborations to stumble, because that's not laid out up front.
Yeah, thanks, Stephen. We've getting lots of questions in. I'm going to try and filter them because we've got another topic to cover, which is the appetite for data sharing, and have we moved to a phase where the public are more willing to share their data? So just for the minute, I'm going to focus on two which have come in. The one here is, do you think the commercial interests of its IT systems, but its technology players, still continues to inhibit interoperability and the ability for patients to own their own medical records? And then summarizing a couple of questions here is, how do we kind of engage the patient more in this, reference to kind of clinician usage, but the patient understanding what the benefit of a digital system is. And I guess that goes to your question, Beverley, about the issue about trust, but it also links to what the audience has said on the poll about it being about data and regulatory issues. Yeah, Beverley, do you want to kick off on a kind of combo of those questions, and then leaving it open for Michael to respond on what he wants of that?
Well, I mean, the question that Cyril's asking about the commercial interests of the suppliers, I just really want to hit that head on. So I spent years standing on platforms in my role in NHS England, shouting at suppliers, saying, come on, you lot, get interoperable, join it up, all that. And then I moved to work for one of the suppliers. And I really, really got to understand how hard it is. And what I'm finding is there is a common theme here. And again, it's partly to do with trust, partly to do with communication, but we don't make it easy. If you want to make a load of money and be a gazillionaire, you wouldn't go into healthcare software in the NHS. It's a fragmented market. You've got to sell it 1,000 times round. It's a very, very high barrier to entry. And so we kind of need to, the more we as the NHS understand some of the drivers and some of the constraints from the private sector's perspective, and are prepared to actually, frankly, pay for the levels of integration that we need. And again, personally, I think the centre should do this. And I do think that a big role for National would be to help seed fund and stimulate the standards and the levels of interoperability that we all need across the sector. Easy to say, difficult to do. And there's not enough time to go into all the difficulties around that. But that would stimulate a level of interoperability for the NHS that we need anyway, and it would stimulate the market. I don't think we should do a meaningful use equivalency, but I do think we could learn the lessons from meaningful use to create a future where we then get a step change in levels of digital maturity across the NHS, and we stimulate the economy, and we get our software supply levels of usability that our clinicians are crying out for. But it's not going to happen if both sides keep moaning and groaning about each other. And that's me saying that, having been the person who moaned and groaned from the centre a few years ago.
So, Michael, do you have a perspective on that? And I'm also going to add in another question which has popped up, which I think is relevant to this, which is considering the NHS is going to be slow getting off its feet, and maybe this is your moaning and groaning point, Beverley, how can we get digital providers adopted at scale in the UK? So I'm kind of knocking some questions off here in one go.
Yeah, I mean, I agree with Beverley that this is an obvious place for government action as well. I mean, we do need policymakers to set priorities, make investments, curate data, create public assets, make sure that we got the right language, help with some of the transparency in the arguments. I think you can't imagine the private sector can solve all these problems, and it's got to be, if we're going to make progress, we've got to see government bodies doing some of those basics. Absolutely. I think on the issue of involving patients as well as clinicians, I mean, obviously agree completely. I was coming at it from the perspective of designing clinician tools, but I think we are incredibly excited about the possibility of digital, this is a little bit comes from our perspective of search. We get many millions of health searches every day now, probably many millions more as a result of COVID. People are hungry for the right information, the ability to take action, to take control of their own healthcare. And I really think this is, many people have talked about digital health being in the hands of consumers, as they call it in the US, or just regular people before, and this could be the moment where people are, there's a turning point on that, and we'd love to be part of that. So absolutely, we've got to engage regular people too.
Okay, so
Sharon, just two quick comments that I think are useful is to Beverley's point, and despite the fact that most people think the US is so decentralized, I will say on data interoperability, there's a historical movement on HL7 and the like, but it's migrated to literally regulations that were coming out, let's call it middle of March, I forget the actual date, about interoperability. And systems were building towards that, IT and providers. And then they put a hold on it because some of the providers said, we're overwhelmed, we can't do it. To me, that's the irony of this. Now is when we need interoperability the most. And I think we've been encouraging our clients to keep moving forward with it because it'll give you a competitive advantage if you can be set up to do that. The other thing, to Michael's point, is we've also seen a huge uptick in, I would say, new primary care models that have a blend of a combination of certainly in-person visits, but moving a lot of it to telehealth and technology use, remote monitoring, and doing that as becoming the new normal in care. And so that is sort of quickly becoming a new model that I think is perhaps a more integrated model that may actually help with the interoperability, because most consumers are going to be on the front lines of, why do I have to re-sign the clipboard about my care? You should already have my record, and I, the consumer, will make sure you have it. So that's another movement that is beginning to take some shape.
So I'm going to just move us on to the kind of the next question, which is data sharing and use. Kind of have the views of the public and patients change? So kind of a series of questions here, I think. But basically going to the heart of, are patients more willing to share data for the benefit of a wider health system? Everybody's been sat at home, worried about their families, worried about themselves. Has kind of that immediate fear kind of changed the way we assess as individuals, ourselves, everyone on this call, and patients more widely, their willingness to share data? And so that's the kind of first question. And then looking at that, what are the trade-offs? Do we think the balance is different? Are patients more willing to share for treatment, or more willing to share if it's improving care, or they know it's going to a pandemic? It's that kind of question. Do we see a difference in the attitude? Michael, do you want to kick off on this, and then Beverley to comment?
I think I would probably return to some of the comments I made earlier, which is I think we're in slight danger of over-interpreting the moment. I mean, certainly, I think the pandemic illustrates very well how sharing of data can be part of better health and better health care, and perhaps has shocked some people into realizing that we don't share data terribly well, or haven't been sharing data as much as they thought as healthcare systems. But I don't think we can presume kind of consent out of this moment. And I do think that it's incredibly important that there is a sort of public conversation about these, about the justification for data, and that it's led by the NHS and others. Obviously, we can we are partners to them, but we're ultimately the processors of their data. I think that there's been some really interesting work on citizens' juries and so forth, exploring what kind of cases do convince people, and it does tend to be where there's a trusted intermediary in the form of a clinician or the NHS that's trusted to look after their data for direct care purposes. And interestingly, there may be more consent for direct care purposes than there are for research or de-identified purposes. But I think the kind of overall point I'd make is I think we're in danger of making a mistake if we think that the consent has been earned by the pandemic rather than earned by making the case kind of cogently and with our partners in the NHS.
Beverley, any views on that? Do you think we're changed? Do you think we're moving into a new landscape, or Michael right here?
A little bit more optimistic, but I do agree with the points that Michael's made. I think to the extent that people have thought about it or paused to think about it, I think people probably are more relaxed about it in general, and I think because we're in the middle of a public health crisis and people have seen the data, I think the graphs, the daily ministerial news bulletin with the graphs and the data, the public, it won't be lost on them that that's coming from somewhere. And for our ability to be able to model and know what's happening has come from data. But just in terms of your second point around the trade-offs about the different the different views, I'm kind of more with Michael on this. I think it's about trust and it's about purpose. And at the moment, the public trust that the NHS has got, it's their best interests at heart, and so everybody's happy to do that. I think we now have an opportunity to reset the narrative with the public. If we had consulted on and devised a policy for a consent model 10 years ago, we would have implemented it by now. So firstly, I've said this many times, people already think that the NHS shares data with itself for the treatment of direct care, and the fact that they don't always still comes as a surprise to many. But on secondary uses, I think if we're honest with the public about what we're using it for, research, algorithms, population health, people will understand. And if we cloak the message in mumbo jumbo language and are obscure about what we're doing, they won't believe us and they won't trust us, and we'll be right back where we started. So for me, I think the key is not to try and go too fast too soon. Let's sort of seize the moment. We've got to deal with linking data. We've got to think about what happens to the insights, the point that Stephen made earlier about who owns those insights and the kind of added value from the data that we're getting. But don't rush to monetize that value too quickly. Let's take the public with us on an honest conversation around, why we're using their data, what it's for. And if we need to say, there's a financial value here from the insights, and here's the financial value it will bring, and we're in a recession, and this could be UK PLC winner, blah, blah, blah. Let's have the conversation, but let's not pretend we're not having the conversation and just push it under the carpet. So there's a plea, and I'll drive this as much as I can within my own sphere within South East London to try and use this COVID moment to sort of reset and get started on that conversation with the public.
So on that note, I'm going to kind of throw it open to our audience on the poll. Can we pop the poll up? This is a question now about how willing we think patients and the public are willing to share their health data for innovation. So I'm going to give everyone a minute to, or not a minute, a few seconds to pop their answers in, press submit. And we'll see if Michael's slightly more negative view prevails, or if Beverley's positive outlook is the one our audience agrees with. Shall we show the results? So a balance between definitely probably he's got 60%.
Good.
And yes, definitely beats unchanged, and less willing to 2%. So that's interesting. Just Steve, does this kind of replicate kind of discussions in the US?
Yeah, I think Beverley put it very well, and the layered approach. I think, again, as I suggested before, patients want to know when it regards to their care, how their providers are going to get their data, and do they control it? And I think that is beginning to emerge. And then this second piece about aggregating data to do population health, I think Beverley's point is dead on. If patients stand back and think, they're going to, if they were COVID positive, unfortunately, they're in the numbers, but how did it get there? And they may not think about that. But I think having the candid conversation of that roll up, people, I think, should feel comfortable about that, because I think for a very, very, very long time, population health and the whole study of epidemiology is based on roll up of population data. And that's been going on for years. And I think because of the, as Beverley put it, the mumbo jumbo, people get lost in the reality of how this actually works. And I do think being part, this is a little philosophical, but being part of a society that is trying to improve healthcare for everybody, part of that is allowing your information to be de-identified, anonymized, whatever you want to call it, so that nobody cares that it's Steve in Boston. They just care that there are 50 of me with the same age, the same physiology, and the same issue with the same or different outcomes. And that gets rolled up so we can build treatments. And we're going to need to see more of this, particularly as, we haven't really talked about it much, as antibody testing ramps up and vaccines start to come into the play. And I think that goes to Michael's point. That's the safety issue. What is the right speed in which we need to go so that we don't have a mistake and a backlash, versus how can we get it to the public, and how can we eliminate, I would say, regulatory hurdles that might have been overdone. And defining what overdone is the art form. And there has to be a lot of discussion about that.
Okay, thanks, Stephen. We've got just over 5 minutes to go. I'm going to read out, there's lots of questions, and most of them are the UK, because I recognise the names. David Dalton, a former big-time trust hospital chief executive, a comment, there's something in the last comment some time ago, 400 plus NHS organisations, each seeking their own solutions, results in fragmentation, diluted project management, and undergearing of impact. I'm going to link that to a question from Jackie Malander. Hi, Jackie. Because in the UK, for the non-UK attendees, we're moving to integrated care systems, slightly like accountable care organisations. Jackie's question is, what impact will the move to ICSs have on the ability of the system to procure cost-effective digital solutions which cross care providers and settings, and where investment in one setting reaps benefits in others? I keep hearing this, not just in digital. So, Beverley, do you want to have a go at that? Yeah,
so I read the question that David posed, and about the fragmentation. We have to have locally bought solutions, because the national programme's too recent in everyone's memory, and top-down buying of systems for clinicians just doesn't work. And we could do an essay on that. We could have our own topic on that. What I think the global digital exemplars had the right idea about taking existing systems and solutions that have been proven and worked across the NHS and trying to get other trusts to use the same buying frameworks, whatever. The idea was a good one. What went wrong was the way that it was funded. It was divisive, because the money went to the top of the tree instead of the bottom of the tree. It's just, a matter of view. But unfortunately, we're going to have to, I think we need to drive forward with that. The level of ownership that we now have in South East London because of the procurement exercise we've gone through and the patient stories with our clinicians means that I'm going to be able to move from in-house built systems to an integrated EHR. And frankly, if that had been enforced on us from anywhere, at ICS level, NHS London level or national level, we wouldn't be able to do it. And on the ICS point, it's oversimplistic. So the local care records that pull together information out of primary care, mental health, local authority and acutes to give a view on what's happening absolutely needs to be corralled at ICS level and at regional level as well. And that's happening across the country through the LICRA programme, the sort of level 1 and level 2. But the operational systems to order drugs, to order tests, to clerk somebody in to ED, to manage referral to treatment targets, blah, 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 is very different in an acute trust, to a mental health trust, to community, to child health, to primary care, to local authority. And so those operational systems, the ability to run an operational system to allow the social worker to receive a discharge or for the pharmacist to get understand drug-to-drug interactions. There is no system on the market, on the planet, that can fulfill all of those operational requirements. And so we have to build interoperability because the level of fragmentation is unfortunately a byproduct of the fact that each of those care settings need different functionality. If you look at a GP practice, the things that a GP practice has to do in EMIS or TPP or in practice is very different to the way in which an acute, so we need to be careful not to oversimplify the approach to systems at ICS level. And I'm sorry I get really excited about this, but...
if I ask Michael, does Zoom explode at 6 o'clock? Can we go on for 1 minute more? It doesn't explode, does it? Anyway, Michael, if it does, thank you. Michael, what do you think about
I have nothing to do with Zoom.
Now,
it won't explode.
in charge of ICS developments in a way at NHS England. What do you think of this question about ICS?
Well, I think that ICS's integrated care systems, for those people who are not embedded in our own lingo, are an effort to stop thinking about healthcare solely in terms of institutions, but to think about them as bigger than institutions and think about populations. And to Stephen's point, I think what it does do is put some emphasis on, look, if we're going to, we can't continue to build hospitals, even especially now, given the onset of the recessions, at the pace that would be required, given what the epidemiology tells us. We've got to, COVID apart, get ahead of chronic diseases. And doing that means investing more in primary care, means investing more in tools that help us be more proactive and helping people themselves look after their own health and healthcare so that they don't get so sick so early. And that's what ICSs are about, I think. And that's to the extent that, there's much that technology can do to help that, but that's what they're really about. It's not really about, to me, procurement systems and so forth.
Okay.
I would just say can I just add on David Dalton's point? I'm more sympathetic to David than Beverley, I think. And I'm specifically sympathetic around the setting of priorities. Like, if we said, look, we really want to if we want some AI applications about breast mammography or finding lung nodules, and this is the data set that's owned, as a public asset, it's curated, this is what good looks like, we would have solutions much faster than we currently do. We're currently kind of being led by suppliers. And I think the fragmentation in the system encourages that sort of behavior rather than being led by the nation's priorities.
Stephen, I think you get the last word about investing across a system. Are there any learnings from the US on that?
I think Michael actually just started to capture it. I think we need a sandwich approach. We need national setting of priorities, but innovators on the private side investing in technologies that make treatments and others go faster and doing that in a digital way. So I think it's sort of this coming together of private-public partnership, which I know exists in the NHS. It exists in the US, probably not to the same degree. But I think there needs to be a recognition that in the US, there is a public system. I mean, Medicare is the biggest payer ultimately, but it needs to figure out a way to align with private investment, and that coming together is something that I think is beginning to emerge, and I hope will continue.
Okay. Well, on the note of public-private partnerships, which is what we're here for, thank you. I'd like to say a big thank you to all our panelists and Sharon for sharing those topics. And thanks to all the attendees, and an apology for not getting to your questions, which a lot of which are great. And I personally hate not being able now to go for some refreshment, especially at McDermott, who have great drinks and canapes. But we'll meet again, as Cyril as the Queens both say. So thank you, everybody, and have a good evening. Thanks.
Thank you.
Thank you.